I'm not happy to lean into 6 months. I don't think that that's something I want to lean into. I think people who go into longevity, it's silly. We've seen that with other toxins in other markets. Don't lean too much. You don't overpromise and underdeliver. I think a lot of people view it the other way. They want to smash that muscle as hard as they can, get this long term. And I think we have to change our attitude away from that, because that just leads to unhappy patients in the long term. I never like to promise too hard on longevity with anything, because I think it's a death knell. Hang your hat on that. It's going to be variance on all people with all products with longevity. So I feel confident talking about the fast effect. I don't feel confident promising longevity to anyone. I don't know why we chase this longevity beast so hard. Like, just let it be.
Welcome to Inside Aesthetics, the world's leading podcast for cosmetic practitioners and business owners.
Our podcasts are aimed at medical professionals and should not be used to make medical, legal, or financial decisions. You should get an appropriately tailored piece of advice from a professional in your country.
To show your support and stay up to date with our latest episodes, click the follow button if you're listening on Apple Podcasts or Spotify. And if you're watching our episodes on YouTube, hit the subscribe button as well as the bell icon.
If you're interested in joining our online community, being a guest on the podcast, or would like to work with us, all of our contact details are in the show notes. And now, let's jump into today's episode.
Hey guys, welcome to chapter 11 of the Tox Talks. If you're new to the podcast, in these episodes we delve into new toxins, how to get the best out of them, differences between them and other brands on the market, and of course we get special guests on to talk about it.
Yes, we're joined by Mike Clague, who's down in Melbourne, very well-known nurse, not only here in Australia but internationally as well. And Mike joined us back in episode 276 for an Injector Diaries episode. And as Jake alluded to, this is a discussion on a new toxin in the Australian market called Relfydess. And Mikey, you're involved in early trials with this. You've used it quite a lot. So we thought, hey, who better to get on and come and talk about this product and introduce it to our audience than the man himself.
Yeah, and also Mikey was at the launch with Galderma. I think it was back in March now. This year's flown by. Yep. So Mikey, first of all, I guess tell everyone about you, your background, if they missed your previous episode with us. Tell us about your practice and your background.
Yep, and keep it under 5 minutes.
Yeah.
So I started the industry about 22 years ago after the launch of Botox. I worked with Allergan, and then from there I went into being clinical manager to launch Juviderm, doing strategy and the clinical training modules for that. And then I worked with them in Asia Pac with the launch of Juve on the training modules for Singapore, Malaysia, India, Thailand, Philippines. Came back, and then I've worked with Dr. Van Park and Professor Greg Goodman for a long time. I have my own clinic called Face Love in St Kilda, and I've published 11 papers now, I think, and we've got 5 Best Paper Awards, which is pretty cool. I recently became a lecturer at Monash University, adjunct lecturer there of practice is the term. Yeah, so sort of lecturing on stuff to do with the industry and compliance and governance. And yeah, I think that's about it in a nutshell. I think what's really important is to just declare my disclosures. So former employee and consultant to Allergan with Botox, former consultant trainer for Hugh Gel for Lativo. I've received free product from Nuceva, and I'm a paid consultant and trainer for Galderma, and I've not been paid for this. This is totally unsponsored talk, so it's just independent. That's really important, I think. Other thing is that in terms of experience with Relfydess, I guess I'm one of 6 people. I think Stephen Liu, Professor Greg Goodman, Edwina Morgan, Van Park, Dan Kennedy. So there was a group of us that got the product in late December, early January. So I guess I'm coming from 11 months of experience, which is, I think globally, that's rare actually. There's only a couple of countries that have launched. So yeah, I guess that's where I'm coming in as an expert, when we can't use the word in Australia, can we? But on this matter, yeah, and I have worked with obviously many toxins. Oh, and the Dysport launch, I did the strategies for the relaunch with the Galderma.
Excellent. So I guess the first question that everyone wants to know is, why on earth do we need another toxin? We've got like one for every day of the week now. So like,
I guess
why do we need another one?
I guess it depends on your country. I think it does seem to be a little more potent. We monitored 10 patients throughout on the app throughout the experience program for a good 6 months. And for that, we measured everything from satisfaction, longevity, the kick in, all of these things. And so it was good to have an objective measurement rather than just your opinion. You were going through it, the first month, first day, first week, 1 month, 3 months, 6 months, so that you actually had something measurable instead of just your opinion, because I think we do get in our head a lot. And they sort of said, I think for us to go for naive 5 people and experienced 5 people, Greg and I are decided to, like go a bit loose. And I definitely tried those people where they're kind of like getting 3 months out of Botox or Dysport and they seem a little dissatisfied. The dose is right. And, I'm big on skin quality, like the needling with the insulin and, like a lot of products you get patients say it's not lasting and it's just their skin quality or, age or fat loss or muscle atrophy over time. These were people that genuinely you could see just weren't quite getting there. And I think where this fits in really well is those people. You can't promise 6 months on it. I definitely see slightly longer longevity. So the people that are coming in every 3 months that seem a little unhappy, I think it fits in really well there. So that's, I guess, what's different. And I guess it's the first of its kind in terms of all the others have been the Hall strain. This is the first new strain that's found in the dirt somewhere in Scandinavia. And it's the first one that's not broken down, freeze-dried, put into another form, then put back to liquid. It just stays in liquid. So it's a more pure form.
So when did you actually get your hands on it? And tell us your early experience. Like, how do you even design your little 10-person trial? Like, how do you get them in? Who did you choose?
Yeah.
And what did you say to those patients?
So I think I was actually the first one to stick it in someone because they were all on holidays and I was the last one working. So if you look, I was still going Christmas Eve, I think. So I did my first couple somewhere around there. And I basically just said to them, this is a newer product. It is TGA approved or on the ARTG listed. Studied heavily that, I don't trial anything that doesn't have good studies. I knew at the time there was about 900 patients through the Ready 1, Ready 2, Ready 3 studies. Good data, good safety data, explain that to them, explain it's a new strain, monitor them through 6 months, did they want to give it a try? And as I said, I picked probably 3 or 4 where they've been struggling with the efficacy and the longevity, and the others were naive or just kind of happy with what they were having. And I explained I just want their opinion throughout that 6-month period to be measured, that they couldn't disappear, need to come back. Yeah, something a bit new and exciting, and they were willing to try that.
Yeah. It's probably worth asking, sorry, David, what toxin were you using before?
Yeah, I think I said this on Injector Diaries. I'm probably a Botox, Dysport, a little bit of Latibo guy, so probably those 3, just all for various reasons. So I guess I launched Botox. I've always found it sort of to be pretty trustworthy. And, I know I'm not going to have any issues, that's for sure. In terms of Dysport, I guess I started with that somewhere 10 years ago. I find it's got a little more grab in the men and for people wanting a little bit of a different aesthetic. And then the Latibo is a very precise one for people wanting that more softer look. So I think that these are all like crayons in the box, really. And you got to understand each one has a personality and you need to want to, I guess, play with those personalities or understand where each one might fit in order to stock more than one. So I see why people struggle with that, but that's where I was before.
So you mentioned that all the toxins have different personalities, and that is an issue for injectors using multiple toxins. And so what would your advice be, or how do you sort of approach a new toxin in terms of, the pattern that you're using, finding out the right dose, how deep you're going into the muscle belly? Like, you hear different things with different toxins, and especially when you're dealing with areas like frontalis, right? It's notoriously an area that can go wrong. So what's your advice on that?
It's a very solid question, Dave.
That's what we do. It's what we do here, Mike. Yeah.
It's like, you're going to get my neurodivergence out there. There's so many factors here. Okay, try and get it to an algorithm. So, first thing we have to understand is that the sites generally decide the look, no matter which one, in my opinion. So,
what do you mean by sites? Where you the injection sites?
The injection sites will decide the relative outcome of the look of it. Generally speaking, none of these are hard rules, okay? And I learned from Michael Caine very early in my life, and then sort of Maurizio. They'll be my 2 main influences. So I've learned from some of the best. And, the site will give you that look, that lift, that drop, that. And then the dose obviously is going to decide your longevity and perhaps the severity of the look, if that makes sense. And then you do have area-specific different rules for different toxins too, I reckon. So the frontalis is such an interesting question. So it's funny how, I remember when we launched Botox, we had problems with frontalis when we only had Botox. That's an interesting. So no one's thought about this. I only know that because I was Mr. Fix-It for Victaz in New Zealand. So Xeomin, problem forehead, next one, problem forehead, Nuceiva, Latibo, it's sort of like, if you step back and look, actually all of them probably had slight issues with frontalis, we just didn't pick it up. So I do think frontalis requires some dedication and some playing around. And I would say with Relfydess, it's been the one area that I found the most tricky to get right.
Right.
And so the dose for me has ended up landing between 40 and 50, which is much higher than I would have used with, say, Dysport, would have been 20 to 30. And so they're supposed to have a similar unit crossover, even though it's more volume. But I do find in the frontalis I'm around that 40 to 50 mark. I think the rest on the advisory board said they were around 30. I know Prof. Goodman's up around 40 to 50 as well. So very good question. But yeah, I think that the sites give you the look. The dose gives you longevity within constructs. I hope that makes sense.
Yeah. What about you, Jake? I mean, when using different toxins?
Well, I guess to summarize the question and also Mike's answer is the problem is we get data for on-label areas. So as I understand it, Relfydess is on label for glabella and lateral canthal lines. Fine. So we don't have any patterns or depth or dose given to us in the study to talk about frontalis.
Right.
And so obviously in our real clinical practice, we're going to go and treat these areas because our patients need it and want it, and that's what they had before. Yeah. So it's kind of on us to intuitively work out where if it's 50 units in a glabella on label, it should translate to a similar dose but spread out for a forehead.
Yeah.
But we've tried that with other products like Lativo, Nuceiva, and other ones that have come on the market, and sometimes that doesn't work.
Yeah.
So like you said, Mikey, I think frontalis is the hardest one to introduce a new toxin to because it's not just dose, it's the diffusion profile we don't understand until we start using it. So I guess if you had to relate Relfydess to Dysport, which, anecdotally we all talk about being a more diffusely spreading particle or product, Nuceiva being a more targeted one. Where does Relfydess kind of perform?
I feel like it's sort of somewhere between Botox and Dysport. It's a little bit more than Botox, a little bit less than Dysport in my experience. And like you said, the on-label, off-label thing is difficult because when you have to teach on label, suddenly you're doing doses that you just wouldn't normally do. I very rarely would put 10 and 10 in a lower lateral canthal line. Like, that's just Simon Cowell. Not that he's had anything, but that kind of, I'm happy, but I'm not happy. And then there's overdosing frontalis. So it's been a bit of a journey. And then like you said, Jake, so in Halo, Michael Caine taught me many years ago to hyperdilute my foreheads with Botox. And I've actually done that for 15 years. I've never not diluted a forehead until Relfydess. So that's another interesting thing. I'm using it as is in its liquid form because the volume is more. I don't really need to, but with Dysport, I would dilute it.
So do we have a simple algorithm that injectors that might be listening to this that want to try different toxins, like they want to try Relfydess in the frontalis? Do we have a simple method that they can use to sort of get comfortable with it? We kind of explained the theory, but I guess just a practical...
Yes and no. With frontalis, there's a technique that sort of Greg and I have used. I've seen Maurizio and Michael Caine. It's almost like an upside-down letter T. It's almost counterintuitive because you're going just above the eyebrow laterally and leaving the superior part. But it actually does elevate the brow and doesn't drop it if you're going about there, just there. Don't interfere with that straight line more than once. And I think that's a Maurizio De Maio thing. It's 2 or 3 times you will drop that straight line. So just once either there will get you the 2 little lines above the eyebrow, not good. Once down here actually elevates it. Once in the middle will drop it. So that's something that I've used with all of them. So a decent dose in the middle. And then making sure that, I guess like Jake said, you titrate your dose based on your glabella. If you're getting a good result with that 50 here, then it should be about 30 in the forehead. Right. But I have found starting with that's not quite enough.
I wanted to ask about sort of, it's a liquid toxin like you said, Mike. Now, Galderma also have another liquid toxin on the market in Europe called Illusience, and we could that in one of our earlier Tox Talks. So I know it might not be launched here in Australia or some territories, but they do have kind of 2 competing new liquid toxins in the same market. Do you find that counterintuitive, or does it make sense to you?
I don't know. After having worked for AstraZeneca and then Allergan and even Boehringer, nothing pharmaceutical companies do is always clear. I'm sure there's a reason. I'm just not aware of it. But no, I don't know. I guess regional approvals, it could be money spent on research, it could be all sorts of things.
So you mentioned that you give your patients a little bit of a spiel around this is a new product, to get your experience. But I guess for the general injector out there who wants to introduce this to their practice, how do they go about, or what advice would you give them to introduce this if they want to move to this potentially in their practice as the toxin going forward?
Yeah, and if I can add to that, how do you do it without adding inherent sort of placebo bias that they think something's changing or that it's you're not overselling it as the new fancy thing? How do you do that so you're getting honest feedback?
Yeah, that's a good question, guys. I would say because overwhelmingly in the feedback in the monitored 10, the fast sort of effect was really dominant. So I'm talking most 50% of mine probably the next day had almost a full kick in, which is rare. I've not seen that. And in the study, it was 39%, I think, had effect by day one. So I just sort of explained to them, because I'm happy now after a year to lean into that. I'm not happy to lean into 6 months. I don't think that that's something I want to lean into. I think people who go into longevity, it's silly. We've seen that with other toxins in other markets. Don't lean too much. You don't overpromise and underdeliver. So the fast kick in, I just say to them, look, in 50% of my patients, they've got a full result within day one, and I'm happy to stick by that. That's the main one.
Full result at day one in about 50% in your hands.
That's what I'm saying. It's pretty amazing. And the rest of them easily fully by day 7. And so that's something that my patients really like. And there's some that don't care, you know what I mean? And then the other group, like I said, that's one bit I talk about. I do say it is new, as in the fact that it's a new strain, and the other strains have all gone sort of down the same path, which is to go freeze-dried or down and back to a liquid. This is liquid, so it should be purer and more effective in theory, but I don't promise more longevity. Generally speaking, they feel a more efficacious effect in most areas. In the masseters, I'm finding it's a bit stronger too. So that would be the main sort of place I lean into. And the second is looking at groups of patients, people who are struggling to get their 3 or 4 months, coming in at the 3rd month, sort of, oh, look, it's not quite as what I wanted it to be. I've just said to them, this is another option for you. It's a different strain. It may work better for you. So I'm always big on under-promising. I don't over-talk anything. I don't jump on trends. I've missed 2, and I'm happy I've missed those 2. I just tell them that and stick with that.
What were the trends that you missed that you're happy you missed?
I think you know. I don't want to get shot. I think that there's a lot of buzz about both, and then I found the efficacy wanting and the data wanting.
Yeah, okay.
I just want to go back to the liquid kind of reconstitution. I mean, a big part of the marketing and kind of a key difference is, it comes ready-made and you don't have to sort of reconstitute it yourself. Do you find that's a massive game changer for you? Does it actually, of course these things take a little bit of time. It's
just like I said with anything, pharma will sort of talk anything up, and I love Galderma. I think they're a good company. I've worked with plenty of good companies with good data. I don't think that's a massive one. I did work it out though. I looked at just the 3 ml syringes. If you didn't have the 3 ml syringes and perhaps drawing up needles, it works out for a clinic of 2 or 3 people to be $3K a year, $4K a year, which Dave will tell you on your top bottom line, $4K a year. You could put that into some Google ads maybe. We can't advertise anything anyway, but you could maybe have a holiday to Thailand. I don't know, but there's a little bit there. And then for the folks that are big on sustainability, there's less wastage, I guess.
Yeah, that's fair enough. A lot was made on, we're not ever going to get, I guess, calculation problems. Now, I guess in an experienced clinic, it would hopefully be a never event. But have you seen bad errors with people putting the wrong stuff in Botox or toxin?
I have.
Yeah. I'm saying these things should be never, but they're not. So I
almost swore there. So I don't know if you're in any of those Facebook groups. I try to stay out, but there's a few, and you will see people in there going, here's the syringe. How many notches is I'm just starting Dysport for the first time from Botox. How many notches is the one to the other?
Right.
And that's there, I would say, twice in every 2 weeks, twice every month. There's at least someone who's going, I'm swapping from X to Y. Who's going to help me? Just to a public forum, which I find mind-blowing. But you do see that. And so this is kind of easy. You just 0.1 ml is 10 units.
Yeah. But I guess it's not really a reconstitution issue. It's just a dummy issue if you don't understand the units. But
I agree. I'm surprised people are that ballsy to announce in a public forum, hey, I have no clue what I'm doing. Help me.
What recon issues have you seen?
Oh, in my own clinics, when I had multiple injectors, they did people that would be using different dilutions without telling other injectors or marking incorrectly on the bottle. I have seen, and Mike, I think you and I were sort of, when we worked together in a previous life or, had business dealings, there was an injector that reconstituted with hypertonic saline. That was an interesting one. So
there's people drawing up with sclero product. There's people, I remember a few times when we were launching Botox, I'd drive away and they'd call and say, oh my God, faulty batch, they're in so much agony. And I'd be like, go check the bin. I think you drew it up with water for injection. They're like, no. They go back and check. Oh, yeah. Oh, and I'm like, the osmolarity has just shattered the cells and that's why they're in agony. So, this stuff does happen. I have heard of also people drawing up with PCDC. which is a wild ride, I'm sure. So you can just have some fat dissolver in your forehead. So no, stuff does happen. Let's face it, we've all been around a very long time. And I think the longer you're around and you are in that complications management space, Prof. Goodman and I do handle a lot of complications in South Yarra. And so you do see stuff that's pretty wild.
So how do you handle if you want to sort of adjust dilution? Is it something you just mess with this product, or you just leave it alone? And if you want to start messing with dilutions, you go to a different product potentially?
Yeah, that's a good question, Dave. I have not really. I'd started off trying to hyperdilute it, and I think it was just too much volume. So no, I just leave it as is. I guess Professor Goodman adds a little bit of 1% lignocaine to it to stop the sting. I don't know how effective that is. I've heard of, I think Dan or Van said they put a tiny bit of bicarb in there to help it be bit less painful. Actually, Dave, you could ask me about that. So
yeah, we'll find a bicarb.
Yeah. Well, now we've mentioned the painfulness. Anecdotally, we have heard, I've not had it injected myself yet, but people saying it's pretty stingy compared to the average toxin. Whether that's going to stop you doing it or turn the patients off, you can tell us, but what do you think?
That's a really well phrased question. So basically what I found with, if I didn't have the 10 and I wasn't tracking the 10 for the 6 months, I wouldn't know that none of them chose to flip back to their old product. So I think that's very, very vital to remember. So obviously it is a little more painful. I do see that. However, that it's not so much that they wanted to go back. And so I think if you weren't tracking it, and I have seen this anecdotally, did you just swap them back because they were a bit more stingy, or did you ask, or what did you do? But at least I tracked them, so I know that they wanted to stay with it. Second thing is definitely is a little more spicy, no doubt. I do use Icy Stick, the green one from the Royal Children's. It goes in the freezer. It comes out at about -3. You hold it on for about 3 seconds before, and then you pop it in. But it's actually from the Royal Children's in terms of reducing pain for, I think, radioisotopic injections into the children.
I have a warning about that product because I got something similar in the UK years ago.
Yeah.
And I actually was treating my wife who's got Indian skin. And
you burned
because
up.
of the freezing effect, it created a sort of a hypopigmented circle on her forehead.
I thought you were going to say you tripped on one and fell on in the shower with it or something.
No. Wasn't going to say that.
How did they get there?
Whoops.
Sorry for that, listeners.
Yeah. No, actually, Jake, I've done that one time. So, yeah, don't hold it on there forever. You're savage. Yeah. Did she do something wrong to you? And you were like, I'm going to brand you.
No, it's just a dummy. This is back in day 2 of doing Botox.
It does come out very cold, so just hold it on for a little bit and then take it off.
Yeah.
The other thing is, like I said, so Prof puts a tiny bit of lignocaine in there. I think Van or Dan Kennedy was using a little bit of bicarb maybe. But the pH is supposed to be 6.75. So it is supposed to be not causing any sort of acidic issues. I'm not sure why it's a little more stingy, but it is a little. But it's obviously not an issue for them to continue on with it.
Right.
Well, pH is logarithmic, so from neutral to 6, quite a big jump, even though it's it's not strong. But what is the liquid? Is it water? Is it saline?
Oh, you're going to go into
else?
this with me? Don't ask me that. That was Greg's part at the launch.
All right, fair enough.
Edit that.
He's gonna.
I'll tell you why I ask. It came up in our Patreon WhatsApp group because
I have it somewhere. I can find it. I just can't remember right now. But
no, that's fine. Yeah, because people were asking about this
I'll ask ChatGPT.
This whole rumor about bacteriostatic saline. Does it potentially reduce the effect of toxins? And also this whole drama about can we reverse toxins by injecting it? I mean, what do you think?
Okay, bacteriostatic saline. So I have worked at Professor Goodman's for 14 years, something like that, and my own practice for 12. One has preserved, one does not. I don't see any difference for starters across the pain. In myself personally, I haven't felt that, but I know that dermatologists, having worked at Allergan and been to Canada and the USA, they love the bacteriostatic. Cool. I definitely do not think it affects potency at all. I've never seen that. I've done thousands of treatments in 2 practices. It's like a blinded study for 10 years. No difference between the 2. So I don't think it affects that. In terms of reversing, I did see and I read that. I think it's Stephen Weiner on that.
No, he was using Hyalase.
Hyalase, that's right.
Yeah,
no, I don't really see how that works, to be honest. Yeah.
Okay, good to know that we agree. Whilst David's still ChatGPTing, I'll ask you another question. So
I got the answer. It says it's a formulation includes various excipitants such as sodium acetate, potassium chloride, etc. But it's not just saline or water alone.
Well, there we go.
There you go.
It's a new thing.
Thanks, ChatGPT.
Proprietary institution.
It's like one of those things when we all got topics to talk about. I was like, Greg's got that one.
Fair enough. Yeah, I was going to ask about the Pearl technology. So when we learn about toxins, even as trainers, we're kind of taught that the difference is the manufacturing, and that's what makes them so different. So what is Pearl technology?
Oh, look, Galderma
was that Dan Kennedy's one?
They love it. Actually, it was Greg's again. So look, it's. I know the first word's like purification or something, but it's basically Pearl technology. They love an acronym, between gain and all of the things that But basically, it's about the process that there's less steps, I guess. So it's less broken down. It starts as a liquid, it finishes as a liquid. And so allegedly it's more pure. It goes through less steps as in precipitation and that kind of thing. And it never gets freeze-dried or brought down to a powder and then brought back to life. So by staying a liquid, they believe that the Pearl technology is unique and keeps it more potent.
Right.
Okay.
Do you want the ChatGPT answer?
It doesn't know.
Tell us.
Okay. So Pearl technology is described as a multi-step, highly controlled manufacturing and formulation process that results in a complex-free form of the active neurotoxin, which is, I'm not going to be able to pronounce
Botulinum Toxin.
that one. Meaning the molecule is produced with minimal extraneous proteins or complexing components. Because Relfydess is ready to use, thanks to this process, it claims to deliver very precise volumetric dosing and enhanced stability.
Well, that's worth focusing on because... Yeah,
what Mike said.
Yeah, well, pretty much, yeah. But like a lot of people, again, people move to say Xeomin because it's the inverted commas pure tox. Now, of course, this also doesn't have complexing proteins, nor does it have human albumin. So what do you think of those kind of points of difference? Is it a big thing for you or your patients?
No. I think it's good that they've gone down that path and they're working on that being purer, less excipients is obviously going to be possibly better. No HSA is always a good thing. But I mean, for me, I feel like, this only came out after the launch of Xeomin, didn't it? And that's like I said, I worked at Allergan, 6 years, no problems with antibodies. I think I saw 4 in my whole 6 years. In my whole life, I've seen 6. True, can't see any response at all. And I think it was a meta-analysis done by Ekram maybe 3 years ago. When I was doing a literature search, it was one of the few I could find that was unsponsored. And from memory, it said 1.4% true antibodies. And that was across cervical dystonia and cosmetic. And it was, I think, Dysport, Botox and Xeomin in that trial. So it all showed up at 1.4%. I could be wrong, but I'm pretty good with my papers, as you know. So for me personally, it has not been a big issue with any of the products I've used. I haven't seen a great problem with people coming in en masse. I have had it said to me that it's just better to put less antibodies into the marketplace, which I think people should be careful what they say because that's a claim that's not really able to be backed up. So for me, I don't find a big issue with the complexing proteins or neutralizing antibodies in my practice.
Right.
Well, it's a weird one, isn't it? Because we're injecting millions and millions of people with all of these brands, and we're only finding 1.4% of antibodies.
Yes.
So why is it only that many?
It depends. If you look at a sponsored study, you might get a different number.
Well, okay, fair enough. But I think we can all agree it's a
low.
very rare, low number that clinically has not zero relevance, but almost zero relevance.
Very little, yes. And I think that people should calm down about it. Personally, it has not affected my practice at all.
Okay. So, Mikey, I want to go back to Onset. You said 39% of people, experience pretty much a full result within 1 day, which is great. But do you sometimes find that would be maybe not an advantage for naive patients who are suddenly changed overnight and everyone's going, whoa, you weren't like that yesterday? It can be a little bit jarring for that new patient. For returning patients, I think it's probably a good thing. But what's your experience with that?
Yeah, so far, no, everyone's been very happy with that. Like, I guess even for a naive person, I would say that's what's going to happen. And I'm not too heavy-handed when it comes to dose. Like, I'm not really big, slam 'em kind of guy. I noticed when I was in America last year speaking in Vegas at BCS, and there was a talk on, like, we need to put more in, get more for longevity. And I'm like, these people are all absolutely not moving anything. So, if you want that really long term, you put a lot in, but then you have that frozen, so I guess because I'm around that 40, 50, full kick-in's not necessarily frozen depending on what I'm treating. You know what I mean? So quite often I might not have treated the forehead, so therefore they don't feel, trapped in their own head, but I get that. But yeah, typically I'm more like a Galapagos kind of go, I don't do a lot of frontalis, so I try to dust that,
Yeah, and we should qualify, that's 39% for glabella. We're not talking
trial that
area.
was 39%. In the trial, that was 39% for glabella and LCLs. So,
okay.
But in my practice, I'm just saying 49% for me personally, roughly 50% are getting it overnight for all areas.
Yeah. Well, at least if you're going to get an eyelid ptosis, you're going to know straight away.
Exactly.
Yeah. Well, there was a ptosis. That was a question that came up. Yeah, you could chat GPT that. There was a question that came up in the launch, and there was one patient with ptosis, but it didn't last more than a normal sort of few weeks, which was interesting.
So that was my point about the speed of onset. If you've got, another toxin that takes up to 2 weeks to fully lock in, sometimes those patients who feel a bit heavy or they complain of can't get my mascara on or of that they kind of can tolerate it if it's a slow burn over 2 weeks. But if it's overnight, wow, I can't raise my eyebrows and I can't get mascara on, that is potentially more.
Well, there's no time to sort of acclimate to the changes.
Correct.
Sort of,
yeah. I feel like though that's like a should you be treating their frontalis kind of deal.
Yeah, sure. I'm just saying that we know frontalis is tricky, right?
If I see a bit of a heavy lid, I'm like, you're not having it. Go get a blef.
Yeah.
Please.
Okay. So you're saying like the onset's faster. What about like the wear off? Is it sort of the same as other toxins, or is there a difference in the way it wears off?
No, it's just a slow burn on the wear off, definitely. I do find, like I said, initially I think it was something like 70% of people in the original glabella trial, Jake, maybe it was just glabella, it showed that something like 72% or something was still having an effect at 6 months. They hadn't sort of dropped off. They went back and looked at that and extended that out. But in my experience, I wouldn't promise more than 4 months. If they get 6, cool. I've already mentioned that it might be a little stronger, and that's all I'll say. And for those ones that are getting longer, they're very happy. But yeah, it just wears off in the normal fashion, I find.
And commercially, if you're treating these patients less often, how does that impact you commercially? Are you charging more for this product, or are you just quite happy that people are going to come back less frequently?
Yeah, look, that's a really good question. I was initially, I think at the launch, that was something that was a little bit, none of us agreed upon. Sachin said that he had charged a bit more for Daxxify in the US when it was promised at 6 months, and he'd had some issues around that. And that was interesting to hear his take on it. We started with 10% more. Now it's the same price. I think the pricing, depending on the person, it's comparable, but with the same price. I guess where I think it can be helpful is those people that were getting the 3 months, they might be at risk of hopping around to other clinics. And so if now you've got something that's working properly for them for 4 months, they're still coming at 4 months. For the people that are going to get 6, I'm not that phased because now they feel like they're being better looked after, I think. And there is an opportunity there always to work on people's skin. And I love talking about the needle with the insulin. I'm mad for it. It works. It's really good. I can talk to them about other skin treatments that might be of benefit as well. So I think it just depends on how you manage your practice and that kind of thing. I don't think of it as a lost opportunity. I think of it as an opportunity to look like a leader.
Yeah, big picture.
What makes you not confident or not willing to sort of say to your patient, hey, there's a potential that this will last, at least 2 months longer than normal? Because if the study says 75%, obviously you can't guarantee everyone. There's 25% who won't. But what makes you less comfortable to make that a thing?
Yeah, I guess it's like anybody. I really like to test what I'm using before I promise anything for starters. So that first 6 months, I was really watching certain groups to see when it chimed out. And it is between 4 and sort of 7, 8. And so I just don't think when something has that little bit of variability that you should hang your hat on it. I also think, like I said, I was in America and someone asked me from a company, like, why do you think this went badly with the 6-month promise? And I was like, look, in America in particular, if you put an ad on the TV and say, your glabella is going to last 6 months, that's all Mary hears. Mary's like, I'm going to get 6 months. Let's take my friends, let's go. But they need to understand, if you want 6 months out of your forehead from any product, you're going to have to smack it, right? You're going to have to dose that thing. And that's going to feel like this. It's going to be heavy. And so I never like to promise too hard on longevity with anything because I think it's a death knell. Like, you hang your hat on that. It's going to be variance on all people with all products with longevity. So I feel confident talking about the fast effect. I don't feel confident promising longevity to anyone because it is dependent on perhaps their age, skin quality, fat loss, atrophy, previous treatments, all these things. So yeah, that's why.
Presumably with your returning patients who you've done a decent dose on and they do get, longer, then you can fall into a rhythm of, okay, well, you're a 6-monther.
Yes.
And for those naive patients who don't, well, you're a 4-monther, and then you kind of work from there, right?
Yes, and that's where I'm at with my second round now on a lot of people. Some are on their third, some are on their second. Here I am November, and some are on a 2 for this year and some are on 3 for this year.
Yeah. And for those endpoints, where they're saying it's lasting to 6 months, is that still like a 2-point on a wrinkle scale kind of outcome, or is it just a bit better and it's not fully worn off?
Yeah, in the study, I think from memory, it's more 1 point. They did do 1 and 2 point. I should be more across that. I apologize. And so, but it is like, I think it's a 1 point right out there past that point. But for me, I'm just looking at that movement of the eyebrow hairs. A lot of people try to look at whether or not the skin is crinkling. I don't look at that. I get them to look at the hair of the eyebrow and give it a percentage score. If pull it to all the way, that's 100, then what is it now? So I asked them that. The first lot I measured, and I have a video I'll send you, which was the first sort of video at the 6-month mark. You can see it's still a good 30% there on those two people.
I mean, even with standard, whatever your flavour of toxin is, at 4 months, the glabella's not normally back to normal because we get it with a bigger dose.
And if you inject low and you're in the origin and you're doing it well in the 7 sites, you will get that depending on the product. I agree. It's that's what I mean. It's like everyone's got a personality and everyone's going to be efficacious depending on how you do it as well.
Yeah. Have you played around with sort of increasing the dosage to get longevity with other products? I mean, we've had like Dr. John Joseph on here talking about his research with the whole dose equals duration. I think he had another acronym. I forgot what it was, but essentially,
that's who I was presenting with in the US. He was on the same panel.
Fantastic.
Yeah,
he's great guy.
Smart.
Great guy.
I love him. But he was sort of showing that there was like he had an upper lip one where he'd gone up to something like 30 or something. I think it's like, look, it just depends. Like, I don't know why we chase this longevity beast so hard. Like, just let it be.
It's true.
Like, Tox for me is a sprinkling thing. I love to work on the thickness of the dermis, right? My patients who've had 4 lots of needling with the insulin topically, their skin is fantastic and it's resistant to movement on its own. Then I'm using the Tox as like an add-on, if you like. Whereas I think a lot of people view it the other way. They want to smash that muscle as hard as they can, get this long term. And I think we have to change our attitude away from that because that just leads to unhappy patients in the long term. They get the atrophy. In Queensland, they're all sun damaged. The forehead's crepey anyways. Like, work on skin quality and reduce the movement. Don't make the whole game, the whole box and dice to kill the muscle for 7 or 8 months. I don't know why we're obsessed with it.
Fair.
I have to say, I've not had a patient say, hey, I wish this lasted a year or longer. They seem happy to come 3 times a year and we're all happy.
And that's what I mean. I found this fit in really well with the ones who are at that 2-month, 3-month, really not getting much. And they're not a big group, but they are unhappy.
But, as you said, Mike, I think John Joseph in his upper lip study, I think he did something
90 units
mental,
of
like 80 of Discord.
Maybe, yeah. Look, I was being conservative. I think it was closer to 50 of Botox. Maybe. It was high. It was really high. Yeah. But she was happy on the video.
Hyper focused.
Yes, it was like some really tiny dilution. Super smart guy. And all the videos were really good and stuff. But for me, I was just sitting there because I was talking about needling and insulin. He was talking about getting longevity. So it was cool. It was like 2 different opinions. But I'm like, I like to really thicken the dermis as much as I can and sprinkle with the Tox,
Yeah. I mean, I guess coming back to, because it's a liquid, you have the ability to hyper dilute, I guess. You can't dial down and make it more concentrated and do, say, cool stuff with the lower face or what John Joseph is doing with the upper lip.
Definitely.
Well, everything's going to have its pros and cons, and we've got so many tools in the tool belt now. It's like, I think that's the next challenge, is knowing what to use when. Yeah. It's getting. Back in the day, Mike, there was 2 products. That's it.
Yeah, it was it. Yeah, and that's what I mean. Like, at least I was around for that, as you guys were, but being close to it, there were problems with them then, and so I guess I'm a little more war ready when it comes to testing something new. Like, I know it's not going to be working straight off the bat. And I do think people these days are very quick to blame a product. Like,
of course,
it's much easier not to look at yourself and what you're doing and just say,
it's a bad batch, Mike.
It's a bad batch.
It's a bad batch.
If I had $1 for every time when we were launching Botox, there was a guy ordering 3 vials a month who were having a bad batch and the cold chain was interrupted, and there was Professor Goodman who was doing 30 vials a month on the same truck. There was no problem.
Yeah.
So I think that we are very quick to blame the product, and we should stop and think, what's my anatomy? What's my dose? What did I do? How old's the person? How I fix the skin? Yeah. There's so many things with toxins that we need to consider before we jump to, I'll just swap it. They've probably got antibodies. Yeah. I've even heard people say there are antibodies in the forehead.
Just in the forehead?
Yeah. You know.
Yeah, of course. That makes sense. Totally.
I've heard that. I'm just like, oh, please, God.
Yeah. So getting to some, I guess, logistical questions, what needle and syringe do you use or prefer, or does it come with its own one?
It comes with its own Relfydess syringe. I think it's called Relfydess or something, but it's like 0.3 ml. It's just like the Dysport ones. They ship it to you with the product, so it's a 0.3 ml. 0.1 is 10 units of Relfydess, so there's 30 units in the 0.3 syringe.
Okay, and what size is the needle? What gauge?
It's a 30. It's like a 31 gauge, I think. It's just the same Nipro as the other ones. It's good. Okay. Silicon, I think. It slides in good. It's all good, yeah.
Fair enough. And then you said dosing-wise, on label 50 for glabella.
And I agree
30
with that.
per crow's feet?
Yeah, I'm probably more 25. I'm like 10, 10, 5 on the lower side.
On the lower one? Yeah.
With the glab, I'd be 10, 10, 10 medially and then 5, 5 laterally, a 7 site.
Okay.
Split that lateral dose, like a 10 unit above the eyebrow is a little heavy duty with volume. So I'd split that into 2 5s.
Yeah. You know, we just got back from Egypt and Canada, and it's amazing how different it is in other countries. And you know, you come from Australia and think, you know, we're an okay market, but we are very advanced compared to some markets. Some markets have never heard of a 7-point or a 9-point glabella. They rigidly stick to 5.
I'd like to think in the early days. In the early days, Michael Clague was brought out. I mean, when I had worked at Allergan, Michael was out, and of course, there was always on label. However, Michael's, you know, he's amazing. To watch him mark out anything, and it's so anatomical. You know, he'll do a gummy smile. It'll be 1.5 units and 1.75. Like, he's looking so closely at what every muscle's doing. And I've learned from him, and that's my first degree. I majored in anatomy. So I learned a lot to look at what you're doing. And I get disappointed that 5-site, we actually just published a paper on this, which is open source, about how on-label teaching is causing odd-looking side effects. So the Mephisto, the Spock, the loss of the Duchenne smile, the grin, you know, so it's hard. Like you said, Jake, you're a trainer, I'm a trainer, but we have to do it that way in those sections. But I think in Australia, we've had leaders like Steven or Professor Goodman or other people that have taught 7-site glabellas for so long. It's just a part of the way we do things. But I do see when I'm overseas, they've never heard of a 7.
Yeah, I think it's completely crazy.
Yeah, I mean, you'll drop the eyebrows, you'll drop it. It's like, stop, think, it's okay. You're actually way past the midline.
Yeah.
I mean, with that in mind, I mean, do you think it's appropriate that pharma is training people on, say, things like toxins, where they're so limited to only teach what's on label and it's not really what's happening in the real world? I mean, are we actually setting people up for failure by actually doing that? And I know that not a criticism of pharma at all, because I know they're trying to help people, but they're so limited and it's so it's not real. Are we creating problems?
Look, according to our publication, yes. But I mean, on the flip side, no, because like they have to have some way to study. And most things coming out of America first, the FDA is quite prescriptive about you must do this 5-site glabella. It must be up here. It must be high. You know, it must meet these certain criteria in centimeters to be in the package insert. So unfortunately, they're handcuffed. And I get that. It's tough for them. And they have to have a way to do it, you know.
I think about it is, let's teach people with the stabilizers on first, the simple way. We're not going to do wheelies and cartwheels yet. You know, just learn the kind of basic bitch way, if you like.
Yeah.
And then in your clinical practice, you're going to have to start treating frontalis, and we can't teach you that because we haven't got a study to show you it. So you're going to have to use your common sense as an experienced injector to extrapolate that data into real world practice. It's kind of,
and I think, you know, Dave mentioned this last time that we were speaking on the Inside Aesthetics, and it's interesting. Like, I think there's a real lack of mentorship that goes on. Like, people should be willing to pay a mentor to go and spend one day every 4 months with somebody experienced and pay for that, you know, because you will get the results if you invest in it. But if you just expect to just pick up a book or watch a video, you know, you might not. And be careful who you're learning from too. But I think that, Dave, you talked about trades and people going through that apprenticeship models. I think that that's missing from our world a bit.
Yeah. Well, Jake and I were just recording some content before we jumped on with you, and, you know, one of the topics was around training. And if I owned clinics again in an imaginary world, so it's never going to happen, I wouldn't let a new injector do anything beyond anatomy, getting a great consult and doing toxin for the first 12 to 18 months. Because I'm looking at like hundreds and hundreds of people's profit and loss statements, and I'm looking at it going, 70 to 80% of your income's coming from toxin. Why are you like trying to learn everything in like 1 year or 6 months? Like, what are we doing?
Yeah. And I think too, like what I would do with new injectors is assign them the clinical paper reading, and then they have to fill in an exam on that, and then get them to do one area 4 times under supervision and then 4 times on their own with the person in the building, and have a process, a ticker box, if you like you would have in any other area, versus getting the companies to do all of your training. I get that's tempting price-wise, but what you will lose in quality might not be worth what you gain in putting the time in as a business owner.
Yeah, totally. How's the product perform in the lower face? Do you have any sort of tips in terms of like,
as far as Mentalis DAO goes, I'm pretty conservative. I'm always low anyways. I'm avoiding the DLI. I stay quite medium on the Mentalis. Laterally in the DAO, 10, so 5, 5, 5, 5 for all of those. 10 and 10 for a standard dose. With the masseters, I find it's very effective in the masseters, which I can't quite understand yet why. So don't use too much. Keep it around 30 per side, I think, because you can collapse the jowl. We can see that. Yeah. So depending on where they are in the past, I'd start with 30 per side and then go titrate upwards if they're used to say 50 per side of Dysport. Butting line's the same, 5 and 5, upper lip 5 and 5, temporalis 15 and 15. Yeah, and I don't do Barbie necks or anything like that. Platysma would be so stupid. Like I did a video on the Trap Tox in the Barbie Tox thing. I don't know if you guys remember when the Metavoy, when they sued Allergan, it was somewhere about they launched Botox the year in Australia, and she sued them because Arnie Klein put too much in the neck. You can look this up. And she said, put more in. But in the third treatment, and if he does any bigger muscles, and I had to work across neurological disorders in my early days, it's kind of potentiates. And so by your third one, you've atrophied that muscle so much that she went on the Disneyland teacup ride and her trap wouldn't hold her head up. And it was whipping around. Yeah, true story. You can look it up. So she sued because she couldn't attend the Academy Awards. She was Hollywood producer's wife. No lies. So I think about that every time I see these, younger injectors. I'm going to slam this, a skinny neck. No, like she's gone on a movie world on the Gold Coast. Her head will snap off. Like, just let's remember, this is a neck and head stabilizer, and we'd have no business being back there, in my opinion.
Yeah, stick to your lane. Do you find that patients are actually asking you for Relfydess? Because, here in Australia, we can't advertise. It's probably not well known that it's out. I mean,
only within the people who've had it. I think the most advocate patients are the ones who are having troubles with their longevity, who now they're getting, let's say 4 months, and we're getting 3, 2.5. They will go and tell their friends, and they come in from them. But other than that, not really. I mean, it is very hard to brand anything in Australia, let's face it.
Yeah.
How are you coping with the new regs? And I mean, it's not really changed much for Victoria in the last year, but for listeners in America, how does it work?
Well, I think it's really interesting. So in Australia, we can't mention a product name, a drug name. We can't say, according to the TGA, anti-wrinkle injections. We can't talk about the injection of that muscle. I've had things reported before. They've been checked. It's cleared. My website's barren now. So I think it is hard, let's face it. I think that there's still a lot of non-compliance, and I'm not sure if you saw 2 weeks ago they changed the fine from $6,000 to $1.6 million. So anyone who's listening who's still skating on the edges on, like $1.6 million now from the TGA, and they've said to enhance compliance. So obviously they're not playing anymore. So I think there's still real. I saw an ad the other day on the Instagram page, and they had Botox and Dysport, then the post above it, they'd gone to B and D. And then the post above it, it's like they were learning, but they've left them all there. So I think a lot of people still haven't read the guidelines, but you really should, because I think the fines will start coming now. And I don't know, Jake, I think you got a letter. I know about 90, maybe 150 people that got a letter that same week. And so I didn't have anything on there. Mine was ghosts from the photos that were there from before that had been removed. And if you clicked on images, it was an Aero 404 page. But obviously someone screenshot it, sent it in. Thank you. Here you are.
Yeah, same for me. It was weird. They send you an alert saying, we've received a complaint. We'll get back to you in 4 weeks to tell you what you've done wrong. I was like, okay, that's weird. So I just went on my website and I tied it up what I thought might needed tightening, even though there was nothing really there. And then by the time that 4 weeks elapsed, they wrote back saying, you're fine. It's crazy.
Back in the day, I remember about 15 years ago, they used to send screenshots. I think since the new guidelines have been so overwhelmed that it's just like a standard response now. Sort it out. We'll go and look in 4 weeks' time. Then when they look, if you still have made no effort and it's blatant, they would go after you. But, there's all sorts of other things too. We forget devices are governed by the TGA as well. So you need to make sure your language around even things like your LED and what you're promising actually lines up.
Do you still do it in units in your clinic? Do you do areas? How do you recommend people do it?
Yeah, I don't care about price. I'm happy to say what it is. I'm $20 a unit for Botox, and I'm $8 a unit for Dysport, $8 a unit for Relfydess. It's all just the same, basically. And, encouraging people to understand the skill of the person, and the knowledge is really important, and the products you choose is a part of that, but paying for the skill, not the mill, as they say. But yes, I think that you just price it the same as you would Dysport, to be honest.
Okay, fair enough.
Awesome.
Any final commercial questions from you?
Really? Not at all. Thank you very much. Appreciate all your time and knowledge. It's always an entertaining chat. Sorry for chat GPTing you. I chat GPT myself all the time, so
it's okay. Look, if it's on if it's on excipients, I can handle it. That's fine. Yeah.
It's like the Joe Rogan. You're the new Jamie of our podcast. Someone in the background.
Except I'm not young.
Yeah.
Not young or very good.
Yeah.
Savage.
No, Mike, thank you very much. We appreciate all your knowledge. And
that's okay, guys. It's always good fun being on. It's a great podcast. I enjoyed very much. Really enjoyed the one with Shino Bay, by the way. It was really good. And always listening. So it's a really good podcast. Anyone, it's your first time, get on it every time. It's good.
Thanks, Mikey.
Thank you, buddy. Take care. See you later.
You.
We hope you enjoyed that episode, guys. To stay up to date with our latest news and episodes, follow us on Instagram, and we're now on TikTok.
You can also now watch our full video episodes on YouTube and Spotify. So if you like what we do, please give us a like and subscribe. Please also consider joining our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, hints and tips videos, bonus podcast content, and more.
All of our social links, Patreon, and contact information are in the show notes below, and we'll see you in the next episode.